We're going to be talking a little bit about specifically bone metastases and treatments for them. I've actually put a couple of slides together just to kind of give a little idea of what radiation is about, because some of you may have had radiation, some of you may not know what radiation is about or why we do it. And so, so we're going to I'm going to go through just a little bit of that, and then we'll sit in front and just kind of answer questions and things like that. Okay. So this is us. Okay, so I'm going to talk about bone metastases and external beam radiotherapy. So in radiation, so I'm a breast radiation oncologist over at SCCA, and I use radiation in the treatment of breast cancers. And preliminarily, I use radiation, well, I guess it's for two reasons. One is in the definitive setting, where I'm getting rid of microscopic cancer cells in the breast or the lymph nodes. I want to eradicate those cells so they don't come back as a recurrence. And so that's one of the ways I use radiation. The other way of using radiation is to eradicate tumor cells when they've left the breast or the lymph nodes and kind of set up shop outside of those areas. And so I'm going to talk specifically about when they set up shop in the bones. So the purpose of the radiation treatment that we give you, there's actually lots of reasons or goals that radiation oncologists have when we're treating with radiation treatment. These are some of the ones that I think about when I see patients. Probably one of the big ones is for pain control. A lot of times patients have little areas where the tumor has kind of invaded the bone and is really destroying the bone and causing pain. And so radiation has been used in that setting to help reduce that. Another way is for preventing fractures, either in the future setting or currently if someone has a fracture from the from the cancer. And so that's another way where radiation is quite effective. But overall, we're basically using the radiation to improve the quality of life. So what I wanted to do was kind of talk about what patients ask whenever I see, instead of giving a bunch of slides about boring studies and stuff, I figured I'd talk about some of the big questions or frequently asked questions that I get from patients when I see them about when I'm asked to use radiation in the setting of for bone metastases. The first one is it effective? Is this really going to work? Is this really going to help at all? The second question is, what's the optimal schedule of radiation? There's 10 treatments, there's 15 treatments, there's one treatment. What's the best one? And then the last question I'm often asked is, what are the toxicities? What's going to happen to me while I get this radiation? So I'm going to touch on all three of those topics today. So overall, radiation is a really effective way in treating bone metastases, and most patients get some form of pain control within 3 weeks of completing radiation therapy. Some people will achieve pain control pretty quick. Sometimes it's during the radiation. I'll see them during their on-treatment visits, and they'll say, you know what, that pain has just, I'm not feeling it as much, or I'm not noticing taking that the pain meds as often. So those are the kind of things that we look for. Sometimes it can take a little longer, but on average, we say about 3 weeks within the completing of treatment, you'll start noticing some comfort. The way we grade pain control has been really a hodgepodge. I mean, some studies actually have the physicians grading, or grading the pain control level, which is, I think, kind of odd, because if I'm not having the pain, someone else is, how am I going to be able to grade accurately how they're feeling? Some have patients grade it, but there was never really a good standardized tool to use. And so this is the international consensus on bone metastasis. It basically categorizes response rates, and a lot of studies will use this category or this classification. And basically, the top two, the complete response and partial responses, those are really what we're striving for as radiation oncologists. We want to get complete pain control for patients when we give radiation, or at least some kind of reduction in the pain control. But those are the top two that we want to achieve. The last classification, the indeterminate response, that was just recently added. It's kind of a garbage, kind of trash can classification, but if you don't have a complete response and you don't have a partial response, but you don't have progression, I guess you can use the indeterminate response class. So what we know about radiation is that several studies using the classifications have found that for the most part, radiation gives about a 15 to 25% complete response rate in terms of pain control. And then partial response rates are even higher, 25 to 50%. This is kind of in general. This is not just breast cancer, but all sorts of, anyone with bone metastases. I just wanted you to focus on this Russian study, which I thought was pretty interesting. They looked at complete response rates in patients who had metastases, and they did include lots of different patients lots of different patients with lots of different types of type of cancers, but about 64.2%, so over 64% of patients who had breast metastases actually had a complete response rate. That was pretty high. And what this study kind of alluded to was that the primary tumor histology was a predictor of radiosensitivity or how you're going to respond. And we know that breast cancers I often tell my patients, breast cancers are radioresponsive. They do really well. Radiation does a really darn good job in eradicating the cancer cells and providing pain control. And this study kind of, supported that. There are some other cancers that are not as radiosensitive, like lung cancers and renal cell kidney cancers. And those, typically, their response rates are a lot lower. But in breast, we do see higher rates. So we're always, trying to be aggressive. And I'm always telling patients, if you have other areas of pain, let us know. We can certainly, you probably will get some good control. And then the other thing that the study showed was that using higher doses and larger doses per fraction was more helpful. And we kind of know that. When we're treating the breast, we often use smaller doses of radiation, typically, but when we're treating areas of metastases, we actually crank up that dose. So instead of doing, 30 treatments or 6 weeks of radiation to a small, bone metastases, we actually smush it into a shorter amount of time, sometimes 2 weeks or less. And what we found was that actually gives a really good response. So one of the things that I think is really confusing is what is the optimal delivery schedule? What is it? Is it the one treatment? Is it 2 weeks? I often will have patients say, wait, but my neighbor got 3 weeks of radiation, or, my Aunt Minnie got 5 weeks of radiation for her bone metastases. How come you're only giving me two weeks, or, 10 treatments, or why are you only giving me one treatment? Well, unfortunately, there's really no optimal timing. There's no optimal schedule. There's no, golden rule necessarily. And basically, when we look at all the studies that looked at this, we really are finding that there's no consensus on which fractionation scheme actually is the best. For a while, people were using multiple fractionation schemes, so 10 treatments, 5 treatments, 4 treatments. And what we found was that they're very helpful and they work, but not one wasn't better than the other. And then more recently, evidence or data has been really focused on looking at single fraction radiation, so a one-time shot to the site. I think a lot of it has to do with the fact that, unfortunately, the healthcare climate here in the United States has been kind of, interesting and very trying. And so we we want to make sure that the treatments are paid for, that everyone is, satisfied. But at the same time, too, we want to make sure that patients aren't spending, 5-6 weeks, in the radiation oncology department. We love seeing patients and stuff, but we know that you guys have better things to do. So we also are striving to shorten our amount of treatments to see if can we get away with doing it over a shorter amount of time, with less toxicity, but with good results. And so I think the single fractionation scheme is also something that we should be using more. I will say that that's been a controversial issue, just kind of that, do you give 10 treatments, do you give 1 treatment? And actually there have been surveys of radiation oncologists in the United States on how they treat metastatic bone disease, and it is pretty just all over the map. There are some folks that will treat for 5-6 weeks, giving lots of little bits of radiation to the site. Some will give shorter courses, and so we've always been trying to find this holy grail, this study that will say, oh yeah, this is the fractionation scheme that works, and this is how everyone should do it. We haven't been able to identify that. The Bone Pain Working Group, they really tried to really make it a point to see if the single fraction was better than the multiple fraction. And what they did was they actually looked at 8 gray times 1, so one big shot to the site of bone, versus a multiple fractionation scheme where you got 4 or 5 fractions. 36% of those patients, a little more than a third, had primary breast cancer. And what they found was there was no difference in time to pain control. There was no difference in maximum pain relief. There was no difference in time to progression of pain. And there was no difference in acute toxicities. So, you know, they really kind of showed that doing one treatment really can give some good results. The only thing that they did see, though, was that the retreatment rates, so the rates of the patient coming back because they are having pain again, was slightly higher when a single fraction was given. Now, is that, you know, compared to if you gave multiple treatments to that site or multiple fractions to that site? I think a lot of that, there's multifactorial reasons to why the retreatment rates were higher. I think that physicians were often our threshold to retreat when we give just one treatment is quite low, mostly because a small dose was given, and every organ in our body has a cap on how much radiation it can get in a lifetime. You know, your brain, your eyeballs, your bones, your breast. And so when you're giving such a small dose, there's a lot of wiggle room where we could go back in and give more radiation, versus if you give 10 treatments, giving a higher dose, the wiggle room is a little bit less. So I think that we often will see retreatments in patients who get a single fraction treatment. This is just another study that, again, another attempt where they tried to see if a single fraction treatment was better than multiple fractions. And RTOG, a now defunct group, is also known as the Radiation Treatment Oncology Group, randomized patients with metastatic breast cancers. And this was just breast and just prostate, so not all sorts of other cancers, because they really wanted to focus on the 2 cancers that are quite radiosensitive. And what they found was they randomized women patients to either 1 fraction or 10 fractions. And they found no difference at all in the response rates. Again, the retreatment rate was slightly higher, so patients were coming back again for more radiation. It was 18% in the single arm and single fraction arm, and 9% in the multiple fraction arm. But again, over 12 other randomized studies have tried looking at this, and they really haven't found the golden, fractionation scheme or the golden schedule that makes sense. And I think if someone comes back for retreatment, it's not necessarily the end of the world. You can give another, another short course, maybe another fraction of 8 gray, and give some good pain control. So I think these are things that we should be looking at as radiation oncologists. So in terms of toxicity, I see you. In terms of toxicity, it really depends on the location of the site. If you're treating, say, the abdomen, the pelvic region, you're going to have side effects attributed to those organs that live in there. So you can have bowel issues, so nausea, diarrhea. You can have rectal pain. You can have bladder pain. If you're treating the chest region, you can damage the lung. You can damage areas that are the heart, the ribs. If you're treating the skull area, then you can cause some toxicity to the brain. So really, it's dependent on the site. I think one big concern that I often hear from patients is, is there reossification of the bone after large fractions of radiation? Well, that's all fancy speak for, does the bone grow back? Once I give radiation, am I damaging the bones to the point where it's not going to grow back and they'll always be weak and fragile? Well, I don't believe so. I think that if you let the cancer cells continue in that bone, that's going to cause bone weakness. Cancer cells will keep eating the bone. I often tell patients it's like a tree with termites in it. You leave the termites alone and let them keep eating the tree, and the integrity of the tree will become really weak. But if you can get rid of the termites, if you can eradicate those and make them all go away, I do believe that there is bone regrowth. And there is data to show that the bone growth and strengthening, we often will see it 6 to 12 weeks after completion of radiation. So we do have evidence that the bone will grow back. So what are things that you can do? I thought this was a really fun study. It was a German study that looked at the role of resistance training. So things like yoga, things like free weight training. I bring this up because I know in the Pacific Northwest you got cafes and yoga studios like at every corner. And so I know people like doing resistance training. Well, what they found was they compared resistance training versus just passive physical therapy during spinal metastatic radiation. And what they found was that the resistance training during radiation yielded improved bone density in the spinal bone metastases. It really actually helped. And the pathologic fracture rates, because the concern is, oh gosh, these bones are weak, and if you do resistance training, you're just going to break the bones. And they didn't see a higher rate of the fractures in the interventional group. So I always tell my patients, I'm a meanie. I make all my patients exercise, whether they like it or not, during radiation. Usually, a lot of people are happy about that. There's always a group that they don't like that so much, but I tell them it's really important to do the exercising. I also feel that we do have studies that when patients exercise, they just feel better. It's good for your mind. It's good for your soul. And if you can I often tell patients, if you can get your friends or families to exercise with you, that's a great way to kind of connect with those folks. And it instills accountability, and it just really kind of motivates you. But also, it also helps to the bones as well. That's it. Thank you. Turn it off, or? Yeah.
Okay, great. So as the bone matrix is being dissolved, there are factors that sit in the bone that actually feed the breast cancer. So it's this we call it a vicious cycle, where the breast cancer stimulates the bone cells that chew up the bone, and then they release factors that feeds the breast cancer, and you get this cycle. Now, we can come in and help slow that down or disrupt it a bit with drugs that probably, if you're in this session, many of you are on, drugs that inhibit or block the osteoclast. And so drugs in that class are either bisphosphonates, like zoledronic acid, Zometa, pamidronate, Iridia, or in another related class called rank ligand inhibitors, and denosumab or Xgeva would fall in that class. Those drugs are given to slow down, block the breakdown. And if you can block those osteoclasts, then you don't get the feedback as the bone is dissolved that stimulates the breast cancer cell. So you can kind of disrupt that cycle. Now, those drugs can be helpful when the cancer's in the bone, but we always give it with additional cancer therapies that could target cells anywhere in the body, right? So we almost never would give just a bone-blocking drug alone. We would give it either with endocrine therapy or chemotherapy or HER2-targeted therapy. And what we're trying to do is slow down bone destruction and prevent those cells from being active and then going out and seeding more life-threatening places. So that's the medical oncologist perspective. Janice gave you a nice overview of how we use radiation, mostly for pain control, and or if we see a spot that looks like it's at high risk for a fracture, to help prevent that fracture and prevent the need for surgery and other things. We don't have an orthopedic surgeon here. We had invited a couple, but they couldn't be here. But sometimes there is a role for surgery, but it's mostly either to fix a fracture that's already happened or to prevent one that looks like it's about to happen, like in the hips, the big weight-bearing places. Also, if you have a fracture in one of the vertebra, one of the spinal bones, there are procedures where we usually use them actually for osteoporosis and vertebral fractures, but you can actually do a therapy where you inject something to help raise the vertebra up again so it's not pinching against the nerves and the discs.
It's like squeezing it. It's like squeezing cement into the area to stabilize it.
Yeah, so that is That's kyphoplasty is the technical name for it. And that's something that can be considered if you have a fracture that occurs in the vertebra, really developed to help people with osteoporosis and those fractures. But we do use it sometimes, especially when you've got a vertebral fracture that's causing a lot of pain. And it can relieve the pressure off the discs. So yeah, we're ready to take some questions. Now, we're told that the live feed can't hear us if we're not talking in the microphone. So do you have a microphone back there? Or can we bring you one? I think we only have this microphone in this room, don't we? So, you want it?
What I wanted to ask is, we've been told that basically if you break a bone, your cancer is going to spread all over your entire body and you're basically done. So how accurate is that, and what would be another answer?
So, a better answer would be that actually having a fracture really doesn't contribute to the spread at all. We'd like you not to have a fracture because of all of the pain and healing and everything that goes with it. But the problem is the cells that are spreading from the bone are spreading through the blood, and they can get out whether you fracture or not. I think the idea that somebody might say that if you fracture, you'd have more access, the cells would get out more, that's just not proven with any evidence that a fracture would increase the ability of those cells to get out. You know, the bone marrow is, your blood filters through the bone marrow. That's where your red blood cells and your white blood cells and your platelets are made. They're getting out into the blood all the time. So those cells that are in the marrow can get out and spread. That's why we've got to do things that stop them from getting out. But fractures really don't increase that. Yeah. So we have another. Yeah. You want to run back?
Yeah, I can run back.
Hi. I had a question about the role of RFA in conjunction with radiation. I have one spot that was treated with RFA and then vertebroplasty and then radiation. So I just wonder.
What we decided was we will both stand here, and then they can pass around the microphone.
I just wonder if this is becoming available for all bone mets or.
So radio frequency ablation, it's not, but it's a way of using
The visceral areas, like the liver. Yeah.
Yeah. So I think when it is used, and I've seen it, we have much more data for the standard radiation therapy. But as Jana said, each organ in our body has a different maximum dose of radiation that you can get. And so once you've kind of hit that maximum and you're worried you can't give more because you'll really cause long-term complications, then we look for other ways of trying to help. And so I think that's when I've most frequently seen it. I have a question for you, Janice, and I'm trying to look at the time. We have time. So another way of delivering radiation in the bone is that there are some agents that is radiation, but you inject it into the blood, and then they are tagged to things that target and get the radiation throughout the whole marrow. So for people who have lots of bone mets that are causing problems in lots of areas, instead of, spot welding and trying to hit all those areas, there are ways of delivering to the bone more diffusely some radiation. And we use it more in prostate cancer than in breast cancer. Tell us about that.
So there's actually several treatments like that. When I was a resident years ago, they used a lot of samarium and strontium. It's basically, just like Julie said, it's an agent that's tagged. It's a radioactive agent that's tagged to basically a dye that goes into the body. And really what it does is it goes to the sites of, especially in the bone, it goes to those bone sites and just kind of latches on and gives out little puffs of radiation from the radioactive source, and it'll just demolish those cancer cells that way, especially when you can't, because we would love to radiate your whole body, but we would hurt you doing that, so we don't do that with the external beam, and so that's another way. Recently there's been another agent that's been used. It's a Radium Source, and again, mostly in prostate. I think there are some thoughts of maybe using it in breast as well, because it's very similar, the two carcinomas. And so I haven't seen any, active studies looking at that, but they have, patients who have been, I think it's called Zofigo. I can't remember what it is. But anyway, the radium agent is actually working quite well in a lot of the prostate patients, and so it is something that we could consider. One of the reasons why I kind of fell away these agents is that as it gets into the bone marrow and kills those cancer cells, it can really drop your counts as well. It can really affect the bone marrow in general. When I do spot welding and I'm hitting just, say, a little area, in the spine, even though I am hitting the bone marrow in that area, you got all that other bone marrow in your body to continue on. So I'm not affecting your counts. I'm not causing, anemias or immune problems, things like that. But when you take these agents like strontium and samarium and you inject that, it goes everywhere. And as it's doing that, though, unfortunately, it really can affect the marrow pretty significantly, to the point where then you might not be able to give other systemic agents if you wanted to, other chemotherapy agents, especially in someone whose counts are so low.
I know that the company that makes the radium is looking at doing some breast cancer trials, but I think that Janice's point that in prostate cancer, up until recently, they almost never used chemo. And so you didn't have to worry about that effect of lowering the blood counts. But in breast cancer, where we more commonly use chemo and other agents that can drop your blood cells, then adding this on top of it has put people in life-threatening situations, and the counts can take a long time to recover, and it's unpredictable with this. So we'll have to be careful. But as I said, a lot of people with bone mets have estrogen receptor-positive breast cancer treated with hormone agents that don't really impact the white cells and the red cells and the platelets. So we are looking at bringing this into breast cancer as well.
Hi. Are there different kinds of bone mets? For example, I'm hormone positive, but my cells, according to the pathologist, were very sclerotic versus maybe osteoclastic. Can you speak to that?
So there are different kinds of reactions within the bone to what the cancer is doing. And most breast cancers are a combination, we kind of call it blastic, which means that you've kind of opened up a big hole, and then blastic means you're growing back in, because the osteoblasts are the ones that fill back in the bone as opposed to the osteoclasts. So you can either have punched out holes, and that would be more kind of the osteoclasts have predominance. The cells that are chewing up the bone are winning, and then the ones that look really dense, or sclerotic is another term for it, that's where the cells that rebuild bone are winning, the osteoblasts. Most breast cancer bone mets have some component of osteoclastic activity going on and osteoblastic activity going on. So at the same time you're destroying bone, you have cells that are trying to heal it up again. And this gets to, Janice's comment about even doing some resistance exercise and stuff. You can help with the rebuilding of the bone in various ways. And when you give the drugs I'm talking about, the osteoclastic drugs, you let the blasts kind of take over and win, and you can heal bone again. So in breast cancer, most bone mets have some component of both. But interestingly, in multiple myeloma, you see no blastic component. And actually, on a bone scan, what you're actually seeing is the osteoblast response. So in multiple myeloma, even though you have lots of disease in the bone scans are negative. Prostate cancer is almost the opposite. They are mostly the osteoclasts are winning. And so you have punched out holes and you don't have a lot of blasts that are trying to reheal it. So you do have different kinds of cancers that are more one or more the other, but most breast cancers have some component of both, and then with different therapies you can shape which is winning. And of course what we want is the bone to be rebuilt again. And so if we can kill the cancer cells in the middle, and they're not taking up space, then you want to encourage the bone rebuilding cells to come in and heal. So if you're told that you have sclerotic looking lesions, that means that you do have more density in there, and in many cases that's because you're trying to rebuild it again.
Now, is that determined off a bone scan or a biopsy?
So it's not determined on a bone scan. It's usually determined on either plain films or a CT or an MRI can tell you, is it denser than the surrounding bone, or does it look like a punched out hole?
And on a CT, you can confirm.
On a CT, you could see that. On just a plain X-ray of your spine, you could see that. That's how it would be determined. We just got the 1 minute warning, so if there's one more question, we can take one last question.
Dr. Kim, you had up on your slide earlier that the radiation can prevent bone breakage. How does that work?
Sure. So basically what's happening, what I tell patients is that if the cancers continue to grow because even as they're growing sclerotically, that's not very strong bone. So when you have a combination of broken up bones, these punched out lesions and these kind of bone growth, this denser area that's not strong, that's higher likelihood of fracturing. But radiation, if I can get rid of those cancer cells that are causing that and then allow the bone to heal up and strengthen up again, that's how I'm able to prevent the fracture. So we're and a lot of times it's hard. I mean, patients will come in with an area in their hip that looks worrisome for fracture, but they have no pain. And so it's often really difficult to tell a patient, I know you don't have symptoms, and I know you're feeling great, and you don't want to come for radiation, and you have other things going on, but, this is an area that there's a lot of weight bearing, or, just a little bit of movement can cause a fracture, and we really want to avoid the big, invasive surgical procedures. And so it's almost kind of an indirect way of helping that bone grow. The radiation doesn't actually help, doesn't help the bone grow. It actually, damages a lot of the areas, but the bone, the way the radiation works is as the radiation goes in there, because a lot of patients will ask, how does radiation know? How is it so smart that it's killing the cancer cells but not the normal cells? And the way radiation works is it's a beam that comes into your body. Your body's made up majority of water. It breaks the water into pieces. These pieces then they get attracted to the DNA of both your normal cells, cancer cells, all cells. It doesn't care. It just goes to these DNA. The normal healthy cells, though, they're able to repair that damage because as those little water pieces latch onto the DNA, they cause a lot of nicks and breaks. And if you can dredge back up to, back and remember your biology class, the double helix, it looks like a ladder. If you break those rungs, that's not a very sturdy, DNA. So basically the normal cells have a repair system that go in and they call them and say, hey, there's something wrong with my DNA. So the little repair systems, they come and fix all that up. Cancer cells don't have that repair system. They're mutated. They just know how to grow. So when they go to grow, they look at their DNA and they have no idea what's going on because it's all broken up and jumbled and nicked. And so that's how radiation will kill those cancer cells. So radiation will kill the cancer cells that are constantly causing these breaks and making the bone weak. So I guess indirectly, and I'm sorry if I didn't mean to say that radiation stimulates the bones to grow, but it does help them to grow because it gets rid of that, the trauma from the cancer cells, the assault from the cancer cells.
So one last take-home point as we end. The middle of your bone doesn't have any nerves. So cancer that's in the middle of the bone is not painful. The periosteum, which is the outside of the bone, is where the nerves are. So unless the cancer is growing out of the bone or causes a fracture that now gets the outside of the bone involved, that's when pain starts. And of course, in the spine, we're also worried about all those nerves that are coming out of the spinal cord. And if you get a collapse now, you can be pinching off the nerves that are part of the spinal column. But the inside of bone in and of itself doesn't have nerves, and so you don't generally get pain until it's starting to cause problems, fractures, or pushes out of the bone.